meeting that in our agenda for today, we have a significant month 7 finance update. In view of the where we're currently at in discussion with commissioners and regulators and others, we determined that we would have that discussion in a private part of the committee. And we've now concluded that. And there will be a formal minute of that discussion which we'll receive in private part of the board in future. But for that reason, we're not going to go over those financial grounds again in this committee, but we'll very much focus on the site-based risks in the standard format for us in R. And we start today with Jonathan, who will have just.
Morning, thank you, Chair. So just to give you a high-level overview of HMB discussions, we had 10 risks rated at 12 at the time of HMB. One has now been downgraded since the meeting, and that's reflected the report in relation to CT reporting. Excluding the finance discussion, which we've done a deep dive this morning, probably a couple of key points just to raise. So from a quality perspective, aortic referrals in an urgent and non-elective position still remain a risk. We have a solution to that. We're just working through it, and we're hopeful that in the January ARC we'll be able to close that or minimise that risk. Two other risks remain in relation to IV line support and pacemaker discussions, which was picked up in strategic partnerships in and around a recall of a pacemaker device. In terms of performance, two amalgamated risks sit together for Broadgreen, and that's in relation to dermatology and overall access targets. And then for LHCH, it's in relation to surgical cancellations, and you would have seen that in the IPR, a spike in the cancellations, which we are deep diving and reviewing at this stage. The final risk on the risk register is an ACHD staffing risk, which we're looking to go out to recruitment over December and January to consolidate that position, and the pod group is working through appropriate actions to try and mitigate the reputational kind of conversation there. Overall, those are the key risks that were picked up at HMB. There were probably two areas of discussion that I'd probably want to highlight. At the moment, you do not see any risks at a 12 rating for digital, but what we did highlight in HMB is that we have a number of risks that are at 10 or 11, that when you amalgamate that is something for us to raise to ARC. We're consolidating that position over the next couple of weeks to make sure that it's reflective and updated to this committee. And the final bit, and I think that's been echoed in the financial discussions this morning, is that we are conscious of some of the morale discussions around continual change, financial recovery that are impacting. And for me at the moment, I've just been in a position of discussing palliative and a closure of a ward to hopefully support the overall system. But given ICB delays of discussions of commissioning, that has really landed badly with staff at the moment. So I'm working back from that at the moment, but I think the committee do need to be cited with this period of continual change. I'm working on how do I improve communications over Q4. So that's a quick and high-level summary from me. No,
it's very helpful, thank you. And David and Mike and I and Sue and Claudette were in the Council of Governors meeting at Heart and Chest earlier this week, and some of the things that you described are clearly, in the broader context, we're all still learning to work with each other. It's there's some anxieties in all of that, which we discussed and are working on. Thank you, Jonathan. Tom, please.
Thank you, David. Very good question, Jonathan. The decline in Welsh activity and income, is that going to be a trend for the future as an end-of-year glitch, or are there particular structural reasons for just at the moment?
So we looked at it at the beginning of the year, and it wasn't based on a reduction in referral demand. We think it's based on activity choices and clinical prioritization. So in month 7, the activity caught up, but it didn't catch up to the full remainder of the beginning of the year. We're hopeful in our remaining forecast that the Welsh activity will increase and it will align to our financial forecast.
Okay, thank you.
Any other questions of Jonathan? Okay, thank you. Natalie, please, Royal
Yeah,
management board.
Couple of significant matters that we discussed. So the first is there are 17 risks on our risk register now, scoring 10 or above, that relate to various admin and clerical vacancies across the site. We, because of that, I asked for a report to be brought to give me an oversight this month around the impact that is having. So we looked at the various KPIs, of which we would look at turnaround time for letters, specialty level vacancies, etc. We concluded that we do feel there is significant operational and clinical risk at the minute across the specialties in managing patients and consultant workload with the vacancies. What we are doing, obviously, in the light of the conversation we've just had on finances and the further restrictions that will need to remain in place until April, Joe Eccles, our Director of Ops, is standing up a task and finish group across the site. So we're going to look at how we best mitigate those risks in those most critical specialties, and the report will be coming back to next month's HMB for me to work through that with the divisional teams. And then we had a specific update on the LQA, which you remember is our ward assessment framework. So just in light of talking about triangulating quality and safety, we had a really positive update from an LQA perspective. Since the framework has been revised, the Royal at the point of HMB had 12 assessments. We've now had 7 golds out of those assessments and 5 silvers. Since that, I've had another gold yesterday. So it really feels, from a ward perspective and feedback when I'm doing walk rounds from the ward managers, they're really welcoming the new framework and they are doing really well on it. So from a quality perspective, really positive results on that at the Royal. From an IPR perspective, just moving on to the key metrics. So a significant challenge facing us at site at the minute is obviously the urgent and emergency care. We've touched on the increasing flu numbers, which is has put significant pressure on us, and you'll see that in the metrics. So increased ambulance handover, delays, but maintaining an average handover of 34 minutes. So although we've seen increased numbers of ambulances and some significant delays, we are keeping that average below target. We've seen some increased 12-hour delays in department, and we've already talked at length about not meeting criteria to side, so we're maintaining that position, but we have got increased pressure on site. The positive I wanted to touch on is the next stage of our integrated discharge plan is to get complex discharges on a Saturday and Sunday. Working with social care and Merseycare, we are going to go live next weekend with the first plan of that across both Royal and Aintree, aiming to get P1 patients home on both sites on a Saturday and Sunday, which is currently one of our deficits. Other highlights in the IPR, so the sepsis metric we've touched on previously, met with the ED clinical team, and they have met with Aintree and are changing their model around assigning a sepsis ACP of the day, similar to what Aintree do. We're going to be reporting that back through Clinical Effectiveness Committee, but we're hoping that that's going to improve our sepsis compliance in the ED. And the final bit, strong elective and cancer performance. The Royal is meeting the elective standards for year end. But the only thing I was concerned about in the IPR were some of the people metrics. So you'll see across mandatory training and appraisal, seen a couple of months deterioration. So we've asked for divisional level trajectories to come back to people in OD next month, and I will monitor that closely through HMB just to make sure that we can improve that compliance and make sure that doesn't deteriorate further. Just moving on to the risks. 2 risks will have positive movement and will be decreased or closed. So we had the risk around endoscopy scopes that were obsolete. We've approved through the capital management group the replacement of those scopes. That is actually also going to have a revenue benefit, because at the minute they are paid for out of revenue through leases. So that risk can be removed. And diabetic foot assessment has been our long-standing risk. We've put an action plan in place with Aintree, and I received a report saying that patient waiting times have reduced and the clinical risk assurance is now reducing as well. So we will be able to reduce that risk score. We had 3 new risks that I just want to make you aware of. So one was around robotic capacity on the Royal site. Primarily, this is impacting now on our cancer standards for urology and for our complex gynae patients because of the limited access available to the robot. The business case went to execs this week. James Thompson has done an awful lot of work with the external suppliers, and we are going to approve and purchase a new robot for the Royal site through the capital programme that should be on site by the end of December. Again, James has been able to leverage some revenue benefits as well in that with the external supplier. There is a new risk around theatre doors. So this is a significant risk at the Royal. We've had it up and down on the risk register for the last 2 years. The estates team put a lot of work into repairing these doors, but there are fundamental issues with the theatre door infrastructure since the new Royal came into place. I'm going to work with Paul Fitzpatrick now. We're going to get some quotes and bring something back to Capital Management Board around what a long-term solution would look like to getting these doors fit for purpose. So I will keep you posted on that one. And then the other new risk to mention is our risk around our digital system we use to monitor our cancer surveillance patients. There have been a few issues and incidents raised around the monitoring of cancer surveillance patients, and the system is not fit for purpose. Beth, as exec lead for cancer, is aware of this with the cancer team, and we are looking at the procurement of a new system. In the meantime, I'm just picking up with Beth and the divisions around what our short-term mitigations are to ensure that we can give assurance that we have the sufficient oversight of all our cancer surveillance patients. But it was just a site arc that is an evolving risk. We will procure a new system, but I will take responsibility with the site teams to look at the short-term mitigation at a specialty level. Other than that, Chair, all the risks are very similar to previous months, and happy to take any questions on them.
Yeah, thank you. There's a good thread through all of the month-on-month reports on these. Any questions or comments in response to Natalie, please? Start with Sue, then David.
Just a quick question on corridor care. There's a spotlight and focus on this issue across the system. I just wanted to whether the Royal, what the Royal's position is on that currently.
Yep, so we currently have 20 patients on our corridor pretty much every day at the minute, Sue. We staff that 1 to 5 patients, so we are always safely staffed on that corridor. We have a SOP in place for it. One of the things you will see, and it was reported in the HSJ, is they're reporting that places are putting more patients on their corridors. We're not putting more, but what we are doing is we put the patients that are waiting for beds, so we're turning that corridor over faster because we're placing them there and then moving to the AMU. So the number of patients on the corridor isn't necessarily a true measure of worsening corridor care. It's a faster turnover of those patients, but we are continuously using corridor care. As I say, we have 20 patients. What I would say, when CQC came, it's exactly as it was when they came, and whilst it is not what we want to do, they assessed us, didn't they, as safe, good care on those corridors, and we've got exactly the same model in place as when we were inspected.
Okay, thank you.
David, please.
Yeah, thank you. A good report, Natalie. Thanks for that. Just turning to my favourite topic, it was a bit disappointed to see that patients meeting no criteria to reside, the last couple of data points have started to go up. Now, I know colleagues will tell me that 2 data points isn't significant and we shouldn't be concerned about it, but it just, yeah, are there any indications as to whether that is at the beginning of a trend, or is it just an explainable blip in the numbers?
Yeah, so David, those on the call will tell you I'm on this daily when I see the numbers. It's 300 today, so it's come back down again overall. So we're not statistically moving anywhere significant. One of the impacts we have got is once we get patients with positive flu samples, which where we've seen the increase, we do see struggles to get them out to care home placements, etc. So that can impact on the delay days. So I think some of it is linked to the presentations of patients, but I'm not concerned at the minute, David. It's come back down, and our delay days hasn't increased overall. So whilst the numbers might have increased, the length of time in hospital hasn't.
Thank you. Thanks,
Mark,
Chair.
please.
Thanks, Nat. A&E is under pressure, obviously, and there's a strong correlation between for our performance and volume of attendances, unsurprisingly. Can we do a bit more sophisticated piece of work on that to see what the correlation is between spike in attendances, ambulance impacts, and therefore type 1 performance? Because if we are going to have the winter that we think we might, it could be unbelievably challenging to get to our target position because of the volume of patients, not because of the way in which we are managing things through. So a bit more research on that, please.
Yeah, absolutely. Thank you, Mike.
Claudette, please.
Oh, thank you, Chair. Oh, thanks very much, Natalie. Can I just pick up on the planned weekend discharges, and just to say how impressive it is you've been able to turn that on. Did you say we were turning it on this weekend?
Next weekend, we're aiming to across both sites. I've asked them for 5 a day from both sites, Saturday and Sunday. So it's only small initially, but we need to just test the process and then increase it.
That's just excellent in terms of the timely delivery of that. Well done. Just a quick question on relating to that. Do we have transport lined up for that? I'm just sort of thinking back to some of the barriers that we may have, and is transport ready for us to deliver that and support those patients?
So we do have transport contracts, but that is a limiting factor, Claudette. And as we establish the TOC and we want a true 7-day service, I think our own dedicated transport support is something we're going to have to look at. If we can get the scaling improvement we need, we could, and we close the beds, we could invest in a transport contract, but that will be something longer term. We need to look at how we establish that. The full integrated services that work the best have a dedicated home first transport service.
That's great. Thanks, Natalie. And the approach and the work that you've undertaken is excellent, and it's going to provide better patient sort of outcomes, getting them home sooner. So thank you.
Thanks, Claudia. Peter, please.
It was just on Mike's point, if I may, Chair, because it might seem asking the same question to me, is that you can see in the entry IPR there is an increase in attendances since the turn of the year. We have looked into that. We do get big spikes in ambulances. We have had days where 100+ ambulances, but the background to it is actually walk-ins, Mike, so it's not ambulances. And therefore the way to maintain that 4-hour target for us at Aintree is our non-admitted performance, because most of the walk-ins don't need admit, not all, but most don't, and therefore that's the relative importance of the same-day urgent care unit for Aintree. And as you know, we're putting half of our attendances through that unit. So our way to maintain that 4 hours with that spike in numbers is to get more people through Sudoku. So that's our plan, to try and maintain that for Windsor in Aintree. A bit different to the Royal.
Thanks, Peter. While you're holding the mic, do you want to go into the Aintree site report, please?
Yeah, happy to do that. So just with the one eye on time, so I'm going to just cover a few things. I'm going to cover the key new risks, and then I'm going to cover UEC performance, although Nat's already said most of it. And then I just want to also just give the position in terms of 65 weeks, and also finally just to talk about IPC concerns that we had at HMB. So in terms of the key risks, you will see there's 19 risks now, sitting 12 and above on Aintree. 4 are new, 3 are escalated. You can almost categorize them. There's 3 related to the maxillofacial unit. Most of those risks we were aware of, and they've been up and down, and a lot of work's been done on them. It's essentially a demand capacity issue. So we've been working on capacity, and there's been some progress in that in terms of ability to recruit. Very difficult to recruit 2 specialists, and I think we're making some progress with some of our plans in the past. But what's driving the increase at the moment is an increase in demand across some of our sort of less specialised work. So we're tracking that through using the hospital transformation plan, as you know, at MaxFax is a key part of that, and trying to replicate some of the work we have successfully done on ENT, making sure that not all of that, or making sure that patients are seen in the appropriate place for them, and that's not always in the tertiary level clinics. So that covers them off. There's something specific in late in around maternity leave, which we are doing our best to address from MaxFax perspective. That's not a patient safety issue. It's more a performance RTT issue, but we're managing that through additional workload. There's another theme around emergency general surgery. Aintree are working with the Royal on that issue because there's some cross-rota pollination between the 2 sites. So both medical directors are working on that risk in conjunction with each other to try and get that sorted. So I'm hoping that risk will come back down. And then finally, there's been a bit of a spike in emergency general surgery theatre demand. And again, we're managing that as best we can be, as we've done in the past, but working with the theatre productivity improvement group and the theatre floor plan and Beth's team to try and get that right size going forward. In terms of UEC, I think Aintree's had a bit of a roller coaster, I think possibly the best way of describing it. So the figures here on the IPR you will see was for October, when we were challenged, particularly around 4-hour performance, and in particular the ambulance handover position. You can see on the IPR that increased to 54 minutes in October, which was incredibly disappointing. There was a couple of things behind that. There was that increase in demand. There was the flu numbers. but also there was infection prevention control issues on the wards, which led to a number of bed closures from an IPC perspective, which put us under significant pressure. Just rolling that forward into November, we did open some additional capacity. We got those IPC beds back and we saw an immediate improvement in our performance. So by mid-month, for our target, performance was back up above mid-50s, and ambulance handover time is back down below 40. I think, as Nat has said, in the last week, then again, the EDs have come under significant pressure, specifically for entry as flu attendances to the ED, and we can see another spike in our flu numbers, and you can see that reported nationally. Also, we have had a number of further IPC bed closures. From the respiratory ward was closed with flu, and we've also had a norovirus, so that is also increasing the pressure at the front door. So we are working with our IPC teams to try and get those beds back open, and lots of work going on a day-to-day basis on using the ED capacity as best we can to offload ambulances in a timely way, but there's still some challenges out there at the moment. Just in terms of elective care, the key issue for entry remains the 65-week position. You can see the numbers on the report. At the end of last month, they were down to 42 long waiters. By the end of this month in November, we're at 11. We know each one of those patients and are working on a daily basis to get those patients seen and treated. One is due, there's about half of them are due to a specific consultant sickness that occurred in November, which hopefully now is resolved, and so those patients will be dated and seen and treated. And then finally, just the infection prevention control issues. I've already referenced these winter type infection prevention control, but as you will see on the IPR, we had a further MRSA bacteremia. This was a complex patient. They've had a full investigation. They were not colonized on their skin with MRSA, but it was a line insertion, which is deemed to be the root cause. As you know, that has been a recurring theme, which we have an action plan around. Nikki Martin has joined us now on site as our new Director of Nursing, and I've just asked her to cast some fresh eyes over that action plan and to work with her teams to make sure that action plan is A, the correct one, and B, is embedded across the entire site. The actual bacteremia we had recently, there was very little learning that fell out of it. In fact, there was a complex patient, but it still prompted us to want to loop back around the action plan to make sure it's the right one for the site. So I'll stop there and just allow any questions.
Thank you. Another good report. Points, questions for Peter, please. Over to James.
It wasn't a question as such as I think you can see in both reports. Again, trying to sort of look for the positives in previous discussions. The decisions made as a board around the winter plan and which things to fund were clearly the right ones. The staffing of the corridors and the testing in particular that we chose to go ahead with within our envelope, and the other stuff we then put back are both areas you can see from the previous two reports that just hit immediately with the flu uptake and then some of the infection challenges and other things. So I think we can at least look back on that now as a sensible set of decisions around winter planning if we're asked later.
Where did we land on the funding of all of that, James? I know we had our own two and we were seeking support for more.
There was a meeting yesterday, actually, I've not had an update on yet, so we just need to do that, but there was a meeting yesterday afternoon.
Okay. Any other points on entry? Okay. When we were in this this meeting with Jim Mackey and Penny Dash, there's a bit of discussion about entry, emergency department, so on. And James made the point, which I think is the most pertinent one on this. Look, I think, whether it's infection control issues or Legionnaires or whatever, things go wrong in an unplanned way. And the real test is how quickly you recover from those things. And it's the right point. And we see in this report, some of the difficulties that were there, Peter, that you had in the October period, and the ambulance handovers going above 50, but the recovery on all of that has been very prompt, and I think is a good sign of the health of the way all that's working.
Yeah, thank you, David. I
Okay.
mean, it's a complex ED. It is Aintree, you know, with the major trauma centre, etc. But it's a very good point about the how quickly you recover from periods of pressure.
Yeah, thank you. Right, Beth's not here. James, are you going to do the DTC risks?
I will. Apologies, Joe. We've got so many people leaving for 2 minutes and coming back. That's because I've had everybody on the call since 8 a.m. And from a succession planning point of view, probably demonstrates the age we're all getting to, because we can't make it to lunchtime. So apologies that you've got people in and out. I would have let them have a break this morning, but there was no time. Right, DTC. Beth's just given me some of the key headlines. Firstly, 5 of the significant risks have reduced around the finances because of improvement in the position. A couple of things that I think the Neds would want to know about. One was the strike action that we had. In particular, we put a training plan into microbiology, which was almost the critical point of an agreement around the strikes, to say this is a gap and we need to deal with it. So there's a training plan put in place. All of that is delivering as planned, so that's all on track. So the commitments we made to resolving those training issues are all on track to deliver. And the action plan around the Fuller report, which you might remember around the mortuary services, is also on track to deliver all of its recommendations in December. So those things Beth went through at the management board, and all were fine. Some other good things in terms of bringing the two together. One is the imaging risks with the Liverpool Women's Risk Register, because obviously the DTC now spans 2 statutory organisations, so they're now aligning those imaging risks with Liverpool Women's, which is great. Some areas of concern we need to know about. The aseptic unit, we had a contaminated culture media in radiopharmacy. So the root cause analysis is underway on that. That'll come next time, whatever the outcome was, but we're yet to identify the cause of that contamination. So that's just underway at the moment. On the finances, I think we agreed we wouldn't cover all these today anyway, but I'm pretty confident that they are delivering an improvement, and the grip and control work, they've identified a further 880k on that, which you've seen in the earlier presentations today. It's part of that number that we went after on the 15 million opportunity on grip and control. So that's been well thought through. The only other thing to note was there was a external audit in radiology at Aintree, which took 3 days, but was all passed successfully. So well done to the Aintree radiology team there. That's all gone without incident, which is great. Nothing else, Chair, really to reference on that today.
Thank you. Any questions or comments in response? All straightforward. Thank you. Jenny, Liverpool Women's Hospital Management Board, please.
Thank you, Chair. I'll do the management board and then take us into the maternity incentive scheme and perinatal dashboard briefly. And we've talked about the finance at the hospital management board as well, though we also talked about the plan for next year, which is imminent in terms of a first draft and some of the risks associated with that, particularly in relation to the ongoing efficiency expectations in light of our structural deficit and the work that we've done to date. In terms of the risks, Liverpool Women's has 7 risks going 12 and above related to operational targets, cash, our isolated site, and pharmacy and meds management. There were no change in the risk scores of those risks following review. However, we did note, and I think we're hearing this across a number of the sites, some emerging themes around workforce pressures and morale. In terms of some of the conditions that we're working in at the moment, in particularly around grip and control, non-clinical vacancy pressures, etc., bank shift rates, and just the wider compound of some of that stuff. So that will be taken through the people group during this month, and I think no doubt expect that to come through here next month in terms of those emerging risks. And like Nat, I think we saw a dip in mandatory training last month as well, which may be indicative of some of that. So we just noted that at the meeting. In terms of then just drawing out some of those issues from there, performance, overall we are seeing the dial turn. You'll remember me reporting in previous months that we were stopping the deterioration. We are now starting to see some improvements, particularly around the waiting list coming down, which is excellent. That's come down, certainly as we stand today, that's come down for the 4th consecutive week. So all the metrics around elective are tracking positively at the moment. We're still behind where we need to be, but we are moving completely in the right direction. Cancer, our FDS and 31-day performance are moving in the right direction. 62 days remains a challenge, and we're still working on that. What we're looking at this every day and every week. What we'll do is at the end of December, so the end of quarter 3, just do that stock check about the final quarter, how those improvement actions that I brought here last month and the impact of those, and review where we are at in full at the end of this month. We also talked in the management board in relation to our transformation plan. We had seen some slippage in that across a number of the programmes. So we instructed a deep dive, which we did yesterday, which was really helpful in terms of getting some of that back on track and understanding what some of the barriers have been, and also some of the work that had really good work actually as an incidental result of some of the work we were doing in our transformational plan. So we'll report on those at the most appropriate time. I think for me that they were the key things coming out. I think for all of us, we all had our terms of reference reviewed, which will need agreeing. I see Daniel nodding. So if we could note those, that the terms of reference were updated and are here for approval. I'll pause there on the hospital management board risk update.
Thank you, Jen. Points or questions? The highest profile issue on has been the elective performance on that. You say things are changing now. Are we clear about where you think you can get to for the year end, Jenny, on all that?
Yeah, I think so, Chair. The difficulty we have is that as we're improving, others are improving as well. So in terms of our relative ranking, that is more difficult. We are heading towards the middle quartile, the third quartile to the second quartile in terms of some of the performance. But we know that our waiting list is one of the biggest and most challenging. So I think when we do a stock take in terms of how those actions that we put in place are working, will be much more clear in terms of the end of December as to what we can definitely achieve by the end of Q4.
Thank you, Jackie.
So thanks, Jen, for the report. I think just need to commend us about the trust around the organisation, the maternity incentive scheme, and that, because I think that's really good. And there's lots of changes going on with the MOS system and all that. So I think there's a lot going on there. I just wondered if you could talk a little bit more about the bank rate. So I know that we've had the bank rate gone in. Why is it, do you think it's affecting Liverpool Women's more than the other organisations, or is it just that we're being more vocal about it?
Yeah, not necessarily any more or any less than any other organisation, Jackie. I think sort of size and scale comes into play in some of these things, and there are particular areas, particularly around the midwifery workforce, theatres workforce in particular, who we're struggling to get shifts taken up, and particularly there was around the doctors as well, the resident doctor rates as well. I've had some conversations with the clinical director around that. There's some concerns there around filling shifts from that point of view. And I think just the overall sort of context of the, Liverpool Women's has been in deficit for 10 years, and we've been working in these conditions for a long time, and they're just getting more pinchier, if that's a word. I think there's a lot of change going on as well. So I think we're just seeing people really kind of, not necessarily taking up shifts in the same way they would. We're losing a little bit of goodwill. So yeah, we're just really monitoring that at the minute, like the others.
Right. So, but we're not worried about any unsafe services. From what I could read in the IPR and everything, it looked okay.
No, we're filling them, Jackie, but perhaps not filling them as efficiently as we could if we had a different bank rate. But we know that we've got to follow the grip and control procedures. No, there's not an issue around safe staffing. When we had our conversation through the hospital management board, that was one of the areas we explored around, was any of this impacting on fill rates from that point of view, and it wasn't. But I think it's got potential to in the future if we can't get that morale and that kind of that goodwill back up again.
Thank you.
David, please.
Yeah, thanks, Jenny. It's a good report. Just a couple of questions on the maternity incentive scheme. You say when you drafted the report that you expected to be fully compliant by the end of November. Were you?
So, David, I was going to take the hospital management board and then come on to the maternity incentive and perinatal dashboard, if that's okay. So if there's no other questions on the management board, I'll pick that up.
Okay, thanks.
Is that okay, Chair?
Yeah, of course, yes.
Yeah. Okay, so again, take the paper as read, and as David has rightly pointed out, there was a risk highlighted, re-safety action 8, around the training. Yes, the team reported post our hospital management board meeting that we were fully compliant across all staff groups for all areas. So we are reporting that all 10 standards are met, and we will be bringing full compliance to sign off at the board in January, and the local maternity and neonatal system will be joining us for that part of the meeting as per the guidance. But yes, we did achieve all 10, which was great, and a real testament to the team and the hard work that's going on. We've seen so much improvement in maternity, and real hard work. We've had some really great feedback as well, so really pleased for the team in that. In terms of the perinatal safety oversight report, again, I'll take that as read. There's nothing specific really to pull out, except just to note that the team have set out the response to the next steps are set out in the Secretary of State's letter in October, in terms of the next steps and things coming out of the investigation that he announced back in the summer. There's nothing of concern arising from that. The team are all over the new reporting standards and requirements, but most of which are already in place. They're just tweaks around the edges for us, really. So we'll pick that up, I'm sure, in our safety champion meeting next week in terms of how that's progressing. But they've got responses to all of those asks.
Thank you. Any other points? Maternity incentive, perinatal quality dashboard. Okay. Anything else, Jenny? We're done.
Thank you.
Very good. Thank you very much. James, anything on corporate risk that we haven't already covered?
I just wanted to say 2 quick things. The ones that are there already that you've seen previously, safeguarding, David is looking for some additional support from trusts across LASP just to keep that shored up. It still sits at a 12. There's something on there that Matt is picking up at the moment around the, sorry, excuse me 1 second. It was the subject access record. So that's in hand as well. Beyond that, not really. I think just a point that we need to revise Finance Risk 9100, because that currently talks about the existing controls and impact. And I think we need to go on to refresh that after today's conversation and just check whether that risk stays in the same place or whether it doesn't, given the conversation we've had about the additional controls. But other than that, Chair, nothing else I was going to raise.
Okay, thank you. Noted. Need to go back and approve the minutes from the previous meeting and note the action tracker for that. So we've had updates today. Any points on the minutes from the meeting on the 6th of November that anyone wishes to raise? The action tracker item around deep dive into sickness rates is going to come back to a future meeting. I think the January meeting. Are we content to approve the old minutes, please? Thank you. The minute of this meeting will include all the necessary apologies, information. Daniel, we've got a terms of reference item, please.
Yeah, just terms of reference. We've updated the terms of reference just to reference heart and chest. There's one amendment that needs to be made to the membership section. It's just to confirm that the membership does also include 5 non-executive directors. It's covered in the chorusing, not in the membership. So subject to that, I'm sure all NEDs want to be part of the committee.
Don't have any choice, to be honest. Are we content on this approval, please? Thank you. James, anything you wanted to highlight on operational performance?
No, not on the operational performance. I did want to just reference the segmentation briefly at the end of the meeting, if that's all right.
Yeah. Well, I think we're at that point now.
Okay.
Sorry, let me go to Mike first. Mike's hands up first.
Sorry, just a quick question maybe for Jim around strike preparation. I think he sort of referenced it earlier on, and strike coverage, please.
So I'll just come back in. Sorry, I nipped out. So strike preparation, we're using EPRR systems as we've used before. Our routine is 2 preparatory meetings every week. We now look at the preparation for Luft, Heart and Chest, and Liverpool Women's. Everybody's up and running doing the prep mic. A bit anxious about the fact that there's quite a lot of annual leave in the weekend, particularly before Christmas, which makes the planning harder. But what can I say? Everybody's on with it. We've agreed the rates as we did before. You know, we've got all the systems in place. So I'd be able to give you more detailed assurance next Tuesday when we have our next meeting, but we're up and running.
Thank you. James, then, any other business, please?
Yeah, I just wanted to share, I mentioned earlier, the latest segmentation is out on the performance assessment framework. Now, what we get is we get a letter which effectively tells us where we are. We've not had all of them yet. We've had them for Heart and Chest, which is basically segment 1, third in the national table, which is excellent. The women's has had a significant deterioration in the table and segmentation. Now, this is not what we get sent. This is our own analysis of the data that sits behind it, so we can try and figure out exactly what's happened. So the women's has gone from a segment 3 to segment 4 and has dropped some 30 odd places in the table. Now, we assumed that might be to do with elective access. It isn't. So what this shows us is the things that have changed from Q1 to Q2 on the table. You can see the access shift is actually not that significant. And we've stayed in domain 3 or segment 3 from Q1 and Q2. The same around effectiveness, the same around patient safety, same around people and workforce. The deterioration is significant, and it's in the finance and productivity domain score. And what we are now pretty clear on is that that is to do with the deficit support funding. So it looks like the women's will have dropped 30 something places and a segment based on purely the DSF payment. So I think that's unfortunate, but we need to highlight that, I think, as a significant issue with these tables for Cheshire and Merseyside trusts. If we look at the Luft one, Luft, we haven't had the letter to tell us which segment we're in, but the data tells us that we would stay in 4. And the individual scores have slightly improved marginally. The one that's deteriorated, again, if you come onto the segmentation scores, access has got better. So we've gone from segment 4 to segment 3. So that's improvements probably in the cancer and RTT side of things, and potentially ED too. The one that's dropped for us is finance and productivity from 2 to 3. And that has fallen in the same way that the women's has, we assume, on DSF. So we're waiting for further detail about it, but I think it's important the board are aware that Luft stays in the same segment, we assume, although we've not had it confirmed in writing, but there's no reason why it shouldn't. The deterioration on Luft is on the finance, probably DSF related, and we'll find out. But the improvement in the access to service domain has outweighed it effectively. So we would stay in segment 4 anyway. For the women's, we just need to go back and understand the significant impact now of this deterioration on the finance score, because it's so significant it pulls the overarching position down to a segment 4. I just wanted to point out one thing on there, that if people were concerned on the experience of care domain shift here, again, we're looking at it, but it's effectively, if you see where my mouse is here, we're right up at the top there, and we've just moved a little bit in the top quartile rather than a major deterioration. So we assume that's a sort of infection related metric, but we're just going to look at it. So that's the latest analysis on it, Chair. I'm happy to share those slides if it's useful for people, but the key thing is really just where we now go as a board in terms of representation around this DSF issue. I think we need to raise it certainly next week at our meeting with the IAG. So yeah, so we'll make a representation Tuesday and just see where we get to on that. But I think the positives are the improvements in the access of care for Luft is to go up a quartile is great, and the improvements we've seen at the women's in the last 2 months are not in this quarter. This was our worst position. So the fact that we've not dropped to 4 on access gives us some confidence that if it's improving, we should start to see that go up in the next quarter.
Okay, thank you.
Thank you.
Anybody want the last word in the meeting before I close it? Okay. Look, I'm conscious that we've rushed through the formal meeting because we had that urgent and important discussion we need to have in private about the financial position. Hopefully we'll communicate with you how we might use some of the time that we've got together in the next couple of weeks, board meetings to continue that process. But by the time we get round to our next ARC meeting, I think it's a week later, isn't it, Daniel, in January, just to get everything ready. So it'll be in the second week in January. I can get back to a better balance across the whole spectrum of risks. So thank you very much for attending. Good meeting. See you soon.